Good morning, listeners and viewers. Welcome to another bi-weekly episode of Fixing Healthcare from the Trenches. I'm Dr. Alejandro Medina, and I am very honored to have a guest today who knows much more about podcasts than I do and about conferences and frankly, about healthcare strategy and policy. So I'm proud to welcome Scott Becker, who is the founder and publisher of Becker's Hospital Review on Becker's Healthcare. He is was the chair of the healthcare division of McGuire Woods, a very reputable law firm with a big focus on healthcare. He is a CPA, which I was not aware of, Scott, by training. He's a University of Illinois guy, undergrad. We did our undergrad about the same time, actually, and then a Harvard Law graduate. So welcome, Scott, to the show.
Oh, Dr. Medina, what a pleasure to be with you. Thank you so much for having me and looking forward to visit with you. It is always a great pleasure to talk to you. So this is a great pleasure. Thank you.
Thank you, Scott. And actually, what a big coincidence that I had done your podcast some weeks ago, and we'll be distributing it in our humble network later today and tomorrow, because I thought that was an excellent discussion where we talked a lot about the sort of Department of Government, efficiency that we hope may spill over to healthcare, right?
I mean, I tell you, what a challenging time and a fascinating time. So many things go right with the U.S. health system, and so many challenges. And those challenges, some of them are getting deeper and deeper. So let's hope there's some hope and positivity in the long run here.
Well, I'm going to bring up something that is very sad. When you hear things like this, although it kind of gets me thinking about what the motivation was, and I want to say this cautiously, but you might have heard that the CEO, yes, of United Healthcare was gunned down this morning, right?
I just saw that this morning, and it does. It's been such a fascinating period of time, and of course, all of our minds go to maybe the wrong spot. I mean, you hope that at the end of the day it was a random thing, but you do think with the and who knows. And speculating, who knows? You think about the managed care payers, they've gotten so sideways with some people on treatments and some other things that you hope it wasn't motivated by, somebody's cancer care being denied, something else like that. You expect that it wasn't, but who knows? You just don't know whether it was random or not.
Well, they're saying it was targeted. They're saying he was definitely targeted because they knew what door he entered. And obviously we can spend the whole 20 minutes talking about this, but you raise a good point, whether it be a patient or frankly a disgruntled, provider, which, we all hate that term. I think you know that, Scott. We are, we're not providers, right? We're physicians, we're nurses, we're PAs,
It would be shocking that it would be a physician, a provider, a system executive, just because they're affected financially by United in a really horrible way sometimes, perhaps, but not a who knows? Speculating out loud, of course. Who knows? A very sad thing to see him gunned down. Very sad.
Our hearts go out to his family and colleagues, and I'll tell you, but it does happen. I trained in New York, so I know the Midtown Hilton very well. It's an old hotel, huge hotel, and I was in New York when several people had gotten gunned down. Physicians. One was an orthopedic surgeon by a workers' comp patient that was upset about being, put on work. And I go through this myself as a hand surgeon. I have a huge workers' comp, and it is a bit frightening sometimes when you say to somebody, look, you have to get back to your life. Yes, you have some impairment. I'm going to speak to the attorneys for the carrier about this, but things do happen.
It's a frightening world. I mean, that's just a horrific thing. We're just seeing it come across the internet now. And again, don't like to speculate on it, but all of our minds go to this horrible place that was somebody that's disgruntled that did business with them, and just who knows?
Yeah, well, sometimes wake-up calls are important, right? So, before we get into that, I do want to tell the listeners I was in Chicago. What was that? A month ago, Scott? For the ASC. So I think people need to know that the whole the Becker's healthcare conference series is quite extensive. In fact, more so than than I fully understand. But I know you've been doing these for close to 3 decades. Am I right?
Yes, no, we're in our third, we're in our 31st or 32nd year,
My
which is just a
God.
frightening thing. But
Praise
yes,
God, yes.
32nd years. We started here. So we started 30 plus years ago, a little bit more than that. We started in the surgery center area 25 years ago, expanded into hospitals and health systems, orthopedic and spine. We're now in several different areas. We have 5 to 7 large conferences a year and a big digital footprint. It turned out that hospitals and health systems, health IT, ended up being the biggest part of Becker's healthcare. But the starting spots were, and we still are very involved in it, were surgery centers and orthopedic and spine. And so we get a chance to see a good deal of the healthcare ecosystem. And really, it's been a fantastic labor of love. Work with great people. I've had a chance to meet great people like
Yeah,
yourself, as
yeah.
well as several past presidents of the U.S. and lots of interesting people. And it's just been a fantastic ride, and we enjoy it tremendously.
Well, you're doing a huge service, obviously, the healthcare industry, because I can tell you, I mean, I've had we were a bit ahead of the curve. My old group of a hand surgery, we had our own operating room. So I've had my sort of own ASC since 1998. And I can tell you, each time I go to your meeting, I learn much more. So I'm honored to be able to participate, as a speaker and a panelist. But I really learn much more, I think, than I impart. So thank you for that.
No, and the whole goal is it's both. You've been doing this for a long time, so you learn so much in your first couple of years. Then you're always learning, like in any profession.
Yes.
As a hand surgeon, you probably learn so much in your first 5 to 10 years, but even so, the next 20 years, you're still learning. You're still learning, and so it's a constant goal. And the goal is to like network, to become a way a little bit motivated again. All of us need to be juiced up again, to be inspired, to be excited, to get to visit with your colleagues. I mean, you and I had a chance to visit in person this last time. Just a pleasure. And so no, we enjoy it tremendously, and we love it, and we love the people we get to meet, which is, to me, is like, I enjoy people and thinking both. So it's just a great
Some
pleasure.
amazing people, and well, you'll be there. I know you guys are so organized. They already had reached out to me like a week after the meeting about my participation for next year. So I look forward to that.
Thank you.
So let's jump into it. What I've done on this podcast is tried to, as you know, it's based on my book, which I know you've looked at, the fixing, basically healthcare from the trenches. But the podcast is Fixing Healthcare. One of the complaints people have about the book, and I say it up front in the introduction, it is not a blueprint solution. The book was written to point out the problems for not from the pundits or the academicians or the bureaucrats, but rather people in the trenches, which I still am, right? I'm a practicing hand and upper limb surgeon. But in the last chapter, the contributors and myself give some inkling as to what we think can be done to fix it. And now the podcast is inviting people such as yourself to actually bring up some solutions that maybe we can really enact. And maybe now with this new administration of, love it or hate it, change brings possibility, I believe. So let us know your top 3 initiatives that you would like to see for healthcare change.
Sure. So I come back to a lot of our problems are supply-demand problems. Just not enough physicians compared to the population we have. There's about 1,060,000 physicians. There's about 340 million people. God knows how many. In other nations that have gotten this ratio wrong, it's ultimately been a disaster. And I look at some of the biggest countries in the world, China and India, 1.5 billion people. They've got a brutal challenge. They tried to move heavily towards preventive care, towards value-based care, towards all kinds of care. But at the end of the day, if you don't have enough doctors, nurses, techs, healthcare workforce, it's a disaster. Now, technology helps, but it doesn't replace. So we've got to fix that. The examples in India and China are daunting. China during COVID, they had to lock everybody down because they shouldn't have enough doctors and nurses in the back end in case people got sick. India went through a period of time where they're just overwhelmed. So I start with supply and demand. And what does that look like? It looks at a few different things. It looks at, and then I'll talk about Medicare Advantage as well in a second in terms of fixing healthcare and getting rid of that. But the first thing is medical education. In some other nations, they produce doctors in 6 to 8 years, not the 8 to 10 years that we're taking. And it's a travesty that we're not doing it quickly. Medical education here is great. We produce great doctors. As you know, I've got a stepchild in medical school. We produce great doctors, but we do it extremely long form, and it's
Yes.
literally ludicrous. It's ludicrous.
Tell me about it.
I mean, you used to have the 6-year med programs. They have them in other countries, Brazil, India. A lot of places do it a lot quicker than we do, and they produce incredibly high quality doctors that we use and have in our country treating us. So it's not like a new crazy concept, but we've got a medical guild, we've got a education developed for the internet. We got to cut a couple of years off it, particularly now that most doctors are going part-time by 40 or so. So your math problem of doctors to people is just completely messed up. It's just off. The second thing is, I could talk about all the prevention, all the technology, all the other ways to go about improving the health of our citizenship. And I know RFK Jr. is big on preventive care and so forth,
Yeah.
but every other place in the world, it's not worked at all. So we could try it. But we could try it. And I like the bully puppet on fitness. I'm a believer in physical and mental health, but we better have enough doctors and nurses on the back end in case it doesn't work. And that's been the case every place. And I have no confidence that in 4 years we'll fix the health and fitness of our country through preventive care. China and India have tried it by necessity, and it's been a disaster. So we got to create quicker medical education. We got to get more residencies placed, and we need so many. Even in the Build Back Better bill or the ARP bill, there's supposed to be 4,000 more residencies. It wasn't passed because it got jumbled into a huge mega governmental plan. Absolutely ridiculous, absolutely horrible. We need those residency spots so bad. There's enough people that want to go to medical school. 25,000 start a year, but they can't take anymore. And there's 50,000 apply that just 25,000, 30,000 just don't get into medical school. And probably 5,000 more of those could be great doctors. We could use them. I mean, the difference between
Yeah.
the last 5,000 that get in and the first 5,000 that don't get in is probably, you could change that difference with a feather. So we need the additional residency spots. Unfortunately, 4,000 is a drop in the bucket, but we need them, and we need them ASAP. And we need them in specialties, subspecialties as well. Everybody talks about internal medicine, the family physician, all great. But the reality is we need a boatload of subspecialists and specialists. We're more and more in parts of the country where to get into a specialist you can't, or to get into one you need to know somebody. A horrendous problem. So I start with those two things.
Well, let me comment on that, because, as you know, there's a lot of concern. I'm an immigrant. I was born in Cuba, and there's a lot of concern about in the immigrant community, and I can understand that. Obviously, the goal, right, is for it to be legal. And one of the things we really should do is recruit more physicians. We need a lot more tech before, the Chinese eat our lunch. We need to recruit and bring in smart intellectual capital from other countries. And that includes physicians. So I can tell you that in Florida, my understanding is our governor is loosening the requirements for foreign graduates to come into Florida, partly because, at least in my part of Florida, Spanish is the main language, and there are a lot of excellent, very well qualified physicians who are in South Florida and can't practice. So that may be one of the solutions. Is, yes, train more, as you say, educate more, shorten the education process, but maybe with a qualified program, bring in physicians, well-trained physicians from other countries.
I mean, 100%. And you're from Cuba. I did not realize, but Cuba's got one of the greatest. I mean, Cuba, for all its negatives, has a great ratio of doctors to people. It's one of the best educated workforces, medical workforces in the country, at least traditionally. I don't know what it's like today.
Well, the problem is they don't have the money. When you're having blackouts, you can't really provide good medicine. And so I can comment on that because I visited. That would be for another time. But yes, there is a tradition, including in my own family, my maternal family, where many physicians I talk about in the first chapter of my book, but they make it an industry. When I did a medical mission in Ghana, they had 2 Cuban physicians there that they were paying $30 a month to, the equivalent of, and Ghana would pay to the Cuban government, and they would sell these people for like cattle, and these poor guys had young children at home in Cuba. So that's what's happening. But yes, we can probably learn something from them, I would think.
But at the end of the day, bringing in immigrant doctors has always been the answer. The downside to it really is our gain then ends up another country's loss. And so that's not here nor there, but it's a reality. We've always solved a ton of our gaps through the immigrant population of doctors, nurses, throughout, and fantastic. And they're part of the greatest assets that our country has, of course, but it is a zero-sum game. So we got to figure out a way to produce more ourselves as well, shorten
Yes.
medical education, improve the residencies, because as we bring in doctors from other countries that already have themselves horrendous ratios, it is a bit of a zero-sum game. But I'm a huge fan of, obviously, it's the backbone of our system is the immigrant community in our healthcare system. At least it's a huge part of it. If not, it's a huge part of it.
It is. Yes.
100%. So we've got two so far. I've got
So supply and demand, and then preventive care, which I agree is a challenge. So
but my first two answers are shorten medical education, increase the number of residencies. The third one is not really solves this problem, but it's to get rid of Medicare Advantage.
Thank you.
Medicare Advantage to me is an absolute disaster. It's a disaster. It's a typical type of thing. We've ended up with more than 50% of Medicare population on Medicare Advantage. The idea was it would cost less, deliver better care. So far, it costs the government more. It doesn't deliver any better care. It's led to a ton of pre-authorization, denials, all kinds of issues. What it's done is just put another tax in the system that really is a whoosh. It's a vacuum to the insurance companies. It's just an absolute disaster. I'm saddened by the pick of Dr. Oz as the leader of
I know. Scott, how do we reach that guy and tell him that one of the richest guys in Miami made his money selling patients like they're heads of cattle? One of the companies was sold to United Healthcare.
Yeah.
Pretty ironic about what happened today for $800 million. Do you think the physicians providing the care got a piece of that? $800 million.
Yeah.
So this is just, they say it, they're managing it. What they're doing really is adding hurdles and obstacles, which actually cost care and delay care. People don't talk about this. One thing is being denied. The other thing is most of the times it ultimately gets authorized. But by then the problem is often either unfixable, much more complicated, or more expensive to care for, which is what I'd love to tell, Dr. Oz.
Yeah, no, Dr. Oz, I don't think cares. Dr. Oz I'm a huge fan. I'm a huge fan of Elise Stefanik. I'm fine with Marco Rubio. I'm fine with many of his cabinet picks. I do think the Dr. Oz pick is just like, oh my God, is obnoxious. It's just like but it's a loyalty pick. He was very loyal to President Trump when other people were not, and he got picked. But he's become a healthcare hustler, and he's sort of like a pro Medicare Advantage guy. Like all these people talk about, value-based care is the biggest ridiculous narrative acronym I've ever heard in my life. This concept of value-based care. This is a concept that is like, if you talk to an orthopedic surgeon who's doing hand surgery on a patient who is providing great care for the fee they get paid, I can tell you that even though the medical establishment might not say that's value-based care, that's value-based care. If you're taking a capitated payment and you're driving your medical loss ratios down significantly, you might call that value-based care. I call that just screwing your patient and screwing your population. That's not value-based care. That's just an acronym for finding different ways to make money. This whole word choice, value-based care, the idea that it attaches politically correct to capitation and not the fee for service is one of the great scams of our generation. I mean,
wow. Folks, you heard it here from Scott Becker. I mean, attorney, healthcare expert. I mean, it's so, Scott, I'm going to launch into my three suggestions, and based on what you just said, I'm going to change my order a little bit. I'm going to say that to me, value-based care is my first solution will be right clinician at the right time. If you get the right clinician, now that right clinician, you notice I didn't say physician. Okay, our mid-level providers do a terrific job and cost less, right? They have less years of education, et cetera. And they do a great job, but you have to see them at the right time. And that's what my Ortho Now model does, right? You have a sprain, a fracture, or pain in your knee, and you get to be seen by somebody that probably can take care of the problem. If they can't, then we use technology through an app to reach out to the specialist. But you don't need to see a guy like me for every person who has wrist pain, because they may have a decorative tendonitis and get an injection, right? So that's right clinician, right time, okay?
Yeah.
The second one is, and you mentioned authorization, right? That is the most inane concept I've ever heard. Okay. What we do need is oversight, right? Because, Scott, like there's, your legal colleagues, there's guys who either aren't good, aren't doing the right thing. The same with physicians, right? There's physicians who are overutilizers or not doing something ethical, or they're simply not well trained. So you need oversight by an insurance carrier. I get that, and even by government agencies. But you don't need authorization because you're asking that every step of the way for that patient journey, I have to ask permission and wait for a number. And even though we can do it with this device in like a nanosecond, right? Somehow it seems to take a week to get the authorization, right? And then that's a week that, of course, they save money, but it's a detriment to care, right? So those are my two. And then the third one is what we're doing and what you've been doing for a long time is public education. Until the public understands what our challenges are, how can we possibly fix it? The public needs, I liken it to, what happened with a few bad cops. My God, it was terrible, right? What a few really bad cops did. But guess what? It woke up a dialogue and the public engaged with this. I don't understand why the public, now maybe that lone gunman today understood it. I don't know. But the public has not become outraged by this yet. And I don't understand. Maybe you have some insight as to that.
I think what happens is there's different parts of the population. There's a part of the population that has always been one. First of all, I love your thoughts on right clinician, right time, pre-authorization, and education of the public. Why has the public not been outraged? And I'll put it in two different categories. There's a part of the public that has been so systematically underserved that until it's a total panic, they don't get the attention they deserve. It goes to the health equities. There's a part of the population that has been underserved for so long. They're just almost used to it, and they're so sick of it, but they sort of accept it because they've been so underserved for so long. And then you've got the other part of the public that's really been well served for a long time. And what happens is until that part of the population that's been well served can't find access, can't find clinicians, nobody really deals with, nobody really talks about it. Because our premiums go up, our monies go up. But as long as we can still get the healthcare we need, we deal with it. And you've got this huge bifurcated, disastrous system from a health equity perspective. And it's not until, like I always say jokingly, Congress and the president are all immune from all the access issues the rest of us have.
Sure.
Because they can always get to wherever they want to when they need to. You and I have better access than most of the world because I could always call somebody who's a leader of a system and stuff like that and say, hey, we got this problem. Can we get in? But it's just a disaster. When you get to that spot, like you're in Florida, and obviously Florida's a place where concierge medicine is taken off because there's just not enough primary care doctors. And so people more and more have to have a concierge and they almost feel like they have no choice. But that's, again, another huge health equity divide because if you can't afford a concierge, you're likely getting slow and bad care. It's a disaster, but it's like many things. Until the problems hit the middle class and the upper class, nobody really deals with them, and we've got to deal with it for everybody.
I think it's a more of it's perceived. I speak to people, in my stratosphere, and yes, like you said, we it's not fair to the less privileged. But even in our class, right, people feel, okay, I paid Blue Cross Blue Shield or my employer every month this escalating premium, and yet each time I go, I have a higher deductible, right? I have more out of pocket, right? But it's a micro problem. In other words, people are upset about it at their own level. It's quite selfish. I hate to say it. It's people at some point. I'm hoping that the public says, okay, if this is happening to me, it's happening to my friends, and it's happening across broader society. And at some point, something's going to snap.
Oh, and that's exactly the issue right there. That is, enough people understand it. That's not just a disaster for them. Think about it. It's a disaster for us. Think about how a disaster is for so many other people. And it just is. It's, to me, it's a lot of it goes back to supply demand problems. This concept that everything should be value-based care versus a freer system that's all ran through 5 or 6 insurance companies. It goes back to medical education. It goes back to not enough residency spots. I mean, Republicans and Democrats all agree we need more doctors, we need more supply, but they couldn't get these 4,000 residency spots passed, which is just a drop in the bucket because of the stupidity of packaging it into some huge mega bill that people can't agree with, but they can agree on these one-off issues. We got to get back to a system that works in DC. I mean, it's a disaster right now in terms of just the division and the inability to do one-off bills that just address problems. Our politicians aren't solving problems. I mean, it just, we got to get back to sort of solving problems, not just talking.
Well, here is one of the things that happened today with this unfortunate executive. They were at a annual meeting of some type, and it for investors. Now, somehow that rubs me the wrong way. Why is it so many industries, or even hospitals, right, are technically, I mean, we know it's a bit of a facade. They're not for profit, but at least they're dumping money back in to the system, and their executives are being paid well, as many times they should be. But why are healthcare companies answering to investors when they're paying the people who provide the care so poorly? Do you think there's a possibility in this administration that we could say, hey, insurance companies should be not for profit? That's a big reach, I know it, but
yeah, I don't think that's going to happen. I think the not-for-profit health system industry is one of the great things in our country. And I watched it for 30 plus years. I started off with sort of closer point to the physician is viewing the not-for-profit health systems as sort of like not really understanding. But I think, if COVID proved anything, they were a huge part of our nation's safety net. I think
yes.
They are so important. I think the healthcare systems are nationally very, very, very important to being the backbone of providing care. When you talk about all these different disruptors, and we haven't really talked about that, but you talk about CVS, Walgreens, Walmart, when the numbers don't work, they get out of it, and they have no choice. It's not a knock on them, but there's just a shortage of supply to fill up their clinics. So they sort of got out of the healthcare business. Everybody thought that was going to be one of the answers. The health systems are still standing, and thank God they are. So I'm a huge fan of not-for-profit health systems. The investor influence in healthcare is very complicated because we want investor influence, but you're right, when our executives spend all their time going to investor conferences, it's like when our congressmen spend all their time going to fundraisers. There's something wrong with that, of course.
Yeah.
I don't see it moving towards not-for-profit, but I do think that the this situation with Medicare Advantage is just a blown out disaster. It's just become a disaster. It's a horrendous thing. It started with, President Trump was a pro, and I'm not one of these anti-Trumper who, oh my God, I wake up in the morning crazy about what President Trump does. I'm just not there. That's just not my perspective at all in the world. But he was very pro Medicare Advantage, and that was a bad thing for all of us. And then President Biden started off anti-Medicare Advantage. Then the insurance companies got to President Biden, and he became pro Medicare Advantage. And it just is it's a complete debacle. It's a horrendous.
Well, Scott, maybe this is what we can do. Certainly your podcast has much more reach, and if maybe we could talk about this more and get to the people and explain to them, because ultimately it comes down to the trenches. I'm not on any Medicare Advantage plans anymore. I can't be. I cannot practice medicine that way. I can't have somebody sitting at a desk every step of the way. So, I told my father, who needs a procedure now, I said, thank God, Dad, you're still on, regular Medicare. And there is no issue. And other people I know are handcuffed by it. So maybe let's maybe depart on a positive, if you will. Let's work together, Scott. I'll be your humble foot soldier in the trenches to try to bring awareness to at least one issue, which is a Medicare Advantage, which we don't want to grow. We'd like it to actually gradually go away.
No, exactly. And I'm not confident it's going to, but one of the great questions you could ask is Medicare Advantage is the worst program in America right now. And it'd be an open, good debate on that discussion. So we're all on board on it. Dr. Padilla, what a great pleasure to visit with you always. What a pleasure. Thank you.
Thank you, Scott. Thank you for coming on. We look forward to sort of, let's say, disseminating these points and getting people interested. So thank you, and I will see you soon. And for our listeners, hopefully we'll see you back in a few weeks with another episode of Fixing Healthcare from the Trenches. I'm signing off, and please give us your feedback. Share this. Argue with myself, or maybe not so much Scott Becker, and bring forward the points, because we need engagement.
Yep.
Thank you, Scott.
Thank you.